Good evening. I'm going to be talking a little bit about prostate biopsy, localization, imaging, image-guided biopsies, the current standards, and where research is headed. So before the 1980s, prostate cancer was mainly biopsied by digital guidance, meaning it was biopsied over the finger of a urologist. Although in the 1970s ultrasound was used, it wasn't until around 1989 that it widely replaced digital guided biopsies. And the advantage ultrasound offered was that it was able to calculate prostate volume. It was able to accurately target the peripheral zone, and this is important because about 70% of prostate cancers occur in this zone of the prostate. And also images or abnormal findings on ultrasound could be biopsied, and this added to our ability to accurately target other prostate cancers. Approximately 1 million biopsies are performed annually, and this number continues to increase because of multiple reasons. One is that patients and primary care physicians are becoming increasingly educated and aware of who needs to be screened. We have lower PSA thresholds, which Dr. Makarov had briefly talked about, which we have what we call age-adjusted PSAs, where we are better able at screening patients that are younger without over-detecting prostate cancers in the older patients. And also, there's different management of prostate cancer. Patients may have options of undergoing active surveillance, and these patients that undergo active surveillance have very low risk, low volume disease, but they're managed or followed with periodic biopsies. And another thing that has gained some popularity is focal ablation, which is focal treatment of prostate cancer. And in these patients, repeat biopsies are done usually to try to adequately map out where prostate cancer is and treat them accordingly. The downside of all these biopsies are that we're finding smaller volume tumors or cancers, and cancers that could potentially never affect a patient during their life. And this, as he described earlier, was that could lead to overdetection and overtreatment. So what factors influence prostate biopsies? The number of cores, the location of the cores, and the method that you do a biopsy, whether it's a transrectal, a transperineal, or a computerized template. So until the 1990s, 6 biopsy cores was the gold standard. But studies had demonstrated that about a quarter of cancers were missed after repeat biopsies, and about half of these biopsies that were missed were actually clinically significant, intermediate or high risk as we categorize them now. So now the gold standard for how many biopsies we take are 12 cores, and they've noted with recent studies is that it's decreased the need for repeat biopsies, and the detection rates are similar and reproduced in the community setting. So the current biopsy strategy, not only at NYU but in the community, is taking 6 biopsy cores from each side. And when they do this under ultrasound, they'll also look for abnormal lesions on ultrasound, and they'll take extra biopsies if they're suspicious of other lesions as well. Another important factor that in detecting prostate cancer is the type of probe that is used, whether it's a side-fire probe that your urologist is using versus an end-fire probe. In a side-fire probe, you come in at an oblique angle, and there's a potential at missing prostate cancer at the polar regions of the prostate, namely the apex and the base. So in the end-fire biopsy probe, okay, all right. In an end-fire probe, the biopsy is taken at a perpendicular angle to the prostate. So you're more likely to detect prostate cancer at the apex as well as the base. And there was a study that compared about 1,000 patients who had end-fire biopsies versus a side-fire biopsy. And there was about a 10% increased detection rate with those patients who had an end-fire biopsy. And the cancers that were missed were mainly at the apex. So what is an ideal biopsy? It should be able to accurately identify the presence of clinically significant cancer, meaning cancer that will affect a patient during their life. It should be able to assess the aggressiveness or the risk of the disease, as well as how much disease, the volume. But not only is a positive biopsy important, a negative biopsy is equally important. It should be able to tell the physician as well as the patient that they're unlikely to have clinically significant disease. So we must weigh the risk and benefits of how aggressive the biopsy should be. We don't want to undersample and miss clinically significant disease, but we don't want to find unnecessary or very small cancers that may never affect a patient. So how well do the current biopsies, or how well are they able to assess the risk of the disease? There was one study that looked at 1,500 patients who had their prostates taken out, and they found about 700 of these patients met criteria for what we call active surveillance, which is where we watch them and rebiopsy them to make sure that their cancer doesn't progress. And so these patients usually have what I call low risk disease, Gleason 6, low volume with PSA values less than 10. And when they looked at these patients and looked at the pathologic specimens, they found that 12% had cancer extending outside the prostate, and about 47% actually had more aggressive disease than was initially thought on the biopsy. And we grade prostate cancer 3, 4, and 5 scores. With an aggressive, what is considered aggressive pathology is a score of 4 or 5, and about 12% of patients actually had a score of 4 or 5. Another thing studies have looked at, is to see how focal therapy treating unilateral prostate cancer has become increasingly popular. And how well does the number of biopsy cores, are they able to assess if prostate cancer is truly only on one side of the prostate? So they looked at patients who had only 6 biopsy cores, between 6 and 12, and greater than 12. And they found that no matter how many biopsy cores that were taken in this group of patients, they could only definitively find on the pathologic specimen, 25% actually had disease only on one side, which meant that 75% had disease on both sides. So basically, we still cannot accurately localize prostate cancer at this point. This is another study looking at the ability to detect or assess whether patients truly have unilateral disease. And they looked at 600 patients who had biopsies that were positive on one side. And they continued to narrow down the criteria for selection to see if they could improve our ability to counsel patients. Even with the strictest criteria, we could only found that 20% of patients truly had unilateral disease. Another way to biopsy is what we call transperineal mapping biopsy. And this is done by a grid. And we take about 32 to 36 cores. So comparing transperineal to what is used commonly now, transrectal ultrasound, these are some small studies. But basically they looked at 40 patients who had negative biopsies, 2 negative biopsies by transrectal ultrasound. And they all underwent a transperineal biopsy after that. They found that even though these patients had negative biopsies in the past, about 68% had prostate cancer diagnosed with a transperineal biopsy. When they looked at patients who had 101 patients who had were candidates for active surveillance, and they underwent a transperineal biopsy, they found that about a third of these patients actually had more aggressive cancer when they were rebiopsied by this method. So what are the pros and cons of transperineal biopsy? For pretreatment mapping, it remains the gold standard, and it's able to identify more tumor focuses than a transrectal ultrasound. And so it's better able to risk assess these patients. But it may not be the most practical way of diagnosing prostate cancer. It requires anesthesia, it costs more, and requires you to go to the operating room. So, and if you wanted to be surveilled actively, you would have to go back. It would be quite cumbersome because every year you would have to go back to the operating room for a biopsy. So currently it's the best tool we have for mapping, but maybe it's not the best long-term strategy. There's another investigational way of biopsying, which is what we call a target scan or a computer-guided template biopsy, which basically maps out the prostate, and it'll tell, to make sure all the regions are adequately targeted, it'll tell where the patient should get a biopsy. It has about a comparable detection rate in prostate biopsy, or detection rate as transrectal ultrasound in detecting prostate biopsy, but a negative biopsy still does not conclusively rule out prostate cancer. So what are the limitations of the current biopsy? We still may miss cancers. We can't adequately localize cancer. And we can't assess the risk and the volume of the disease with that much precision. So there's research going into other improving ultrasound techniques and imaging, such as color duplex, power Doppler, and these are basically ways to see how blood flows to the prostate. Like most cancers, they have increased vascularity, so they should have increased blood flow. And if you look at different areas that are having different areas of blood flow, these there are studies looking to see if you biopsy these areas, does it improve your detection rate? One thing that is occurring, investigating at NYU is MRI and the use, and it's the way the different tissues, prostate cancer and normal prostate tissue function, as well as how they image differently under IV contrast. So what could an MRI offer? It offers a more detailed analysis of the whole prostate gland. It's potentially better at identifying higher risk prostate cancer, and which can be targeted for biopsy. You can do MRI guided biopsies and potentially also reduce the need for biopsy, and I will go into all these points in detail. What are the limitations of MRI? You can't necessarily correlate the ultrasound findings with the MRI findings. So it may be difficult to identify that lesion you see on MRI on an ultrasound. And if you wanted to do an MRI guided biopsy, you need special equipment. So these are some images of a prostate on MRI. And you see that the prostate has two distinct images. The bright outside, what we call the peripheral zone, which I had mentioned earlier, about 70% of prostate cancers occur in this area, and a dark central gland. Now, prostate cancer appears dark on this, what we call T2 weighted image. And here we see it's all bright except for this focus that's dark. Similarly, this is the prostate gland, and you see that most of this right side is dark. And when these prostates were taken out, it correlated with prostate cancer on the outlined areas. Now, what are the limitations of pitfalls? And here you have an image of same image of a T2 weighted prostate, and you see that the right side of the prostate appears a bit dark. Initially, you would think that this is highly suspicious of a tumor of focus of tumor, but in this situation, it's actually related to inflammation or prostatitis. So how can we better assess or increase our suspicion of prostate cancer and not misdiagnose it? We can look at the functional parameters. We can look at the way diffuse weighted imaging, which is how water is moving within the prostate tissue, how it reacts to IV contrast, and spectroscopy is basically the metabolic function of the tissue. So diffuse weighted imaging basically reflects how water molecules move randomly into space. In prostate cancer, there's more cells, there's less normal architecture, so water has a restricted movement. And there are two sets of images that the radiologist will look at. They look at what we call trace diffuse weighted images and apparent diffusion coefficient. These are very technical terms, but I'm just going to show you what the tumors look like or suspect focus looks like on the images. It's going to appear bright on what we call the DWI and dark on the ADC. And this is maybe more than you guys need to know, but I have plenty of pictures to help clear things up. So here you see a dark area on T2, which is what you expect in a normally brighter area, the peripheral zone. Here, not so well it's seen, but it's a bit of a darker focus on the left-hand side of the prostate. When you look at the two sets of images of how water is moving, you see a clearly bright area on the DWI, which is dark on the ADC. Now, this is all characteristics after research has been done. This is what prostate cancer looks like on MRI. Similarly, you see a not so clear image on the T2, a little bit clearer when you look at how water is moving within the tissue. Now, what about IV contrast? The patients can be given IV gadolinium, and this is only given in patients that don't have significant kidney disease. If you get significant kidney disease, you're not eligible to get IV contrast. And we look at the, basically what you're looking at is, as I mentioned earlier, prostate cancer has increased vascularity. So when you give something IV, it'll uptake that contrast quicker, it'll be more concentrated, and it'll wash out quicker. So we call it early enhancement, greater peak enhancement, and a more rapid washout. So what do we see? We see that there's a dark area in the posterior part of the prostate. Although most of the prostate cancer lights up, this part lights up a little bit brighter. Similarly, that was a questionable area in the bottom left-hand side of the prostate, which clearly enhances when IV gadolinium is given. So looking at what we call this multi-parametric approach, using multiple modalities, how does this improve our detection rate? The accuracy improves up to 86%, improving our sensitivity, meaning we're capturing more patients with prostate cancer, able to diagnose them better. This is kind of putting it all together. You see that this, with a radiologist's eyes, they clearly see that this is the darkened area, but in our eyes, maybe you can't tell so well. And when you give IV contrast, it's still not so clear because the whole prostate is kind of lighting up. But when you look at the way water is moving, all of a sudden, there's distinctly an area that appears clear to be abnormal. So now we'll look at how does a magnet strength affect our ability to detect prostate cancer? The stronger the magnet, the better the resolution. So you'll be able to detect smaller cancers. This is a 7 Tesla. That was a 3 Tesla. 7 Tesla. This is basically almost, has an appearance of a pathologic light. It has such good detail. So the advantages of having a stronger magnet is that we can detect smaller cancers and be able to see if it's also spreading beyond the prostate, which again, this is all investigational at this point. But not all tumors are going to be easily visualized. One thing we have noted is that the larger the tumor focus, the easier it is able to be seen, and the more aggressive or the higher risk of prostate cancer because of a disruption of the normal architecture is easier to be seen on MRI. This is an example of, on the left-hand side, the prostate appears normal on MRI. On the right-hand side, you see a small area that's a bit darker. Both have tumor. One you see it and one you don't. These are both low-risk disease, probably because the architecture is not too abnormal from the rest of the prostate. So how can we use MRI in a more practical setting? In patients who are candidates for active surveillance, an MRI may help in determining whether they are truly candidates or not. If a tumor is visible on MRI, they're more likely to have cancer progression on active surveillance. And could an MRI, and this is all a bit early to say, but this is a theoretical possibility, could an MRI visibility be a surrogate measure for lethality? So here's an example. A patient had a biopsy. He had low-risk disease, Gleason 6, and only one core that was taken. He gets an MRI, and it shows us a highly suspicious finding in the central gland, which was biopsy. He ends up actually having Gleason 7 prostate cancer, gets his prostate taken out, and it showed that actually some of the tumor was extending beyond the prostate. How does an MRI affect patients who have elevated PSAs, but their first biopsy is negative? Maybe it can raise the accuracy of repeat biopsy by identifying suspicious areas to target. In one study, 54% of cancers diagnosed on repeat biopsy detected only because of MRI targeting. So if an MRI is normal after one negative biopsy, maybe there's a high chance that they are not having cancer at all. So here's an example of a patient who had a negative biopsy. He had an MRI, and it showed a focus of tumor, or suspicious of tumor, in the anterior peripheral zone. It was biopsied, and it was shown to be prostate cancer. So what are the pros and cons of MRI-guided biopsies? It could potentially minimize the biopsy cores needed, may improve the yield or increase the yield in repeat biopsy settings, and maybe because you're only seeing aggressive and large tumors, you're only detecting significant disease. The cons: it costs more, it requires more time, and you need MRI-specific instruments to biopsy. And if you do this as a primary setting, namely in patients who have elevated PSAs, they get an MRI before a biopsy, if you're only going to biopsy those areas that look suspicious, could you potentially be missing biopsy cancers in other parts of the prostate that you normally would be sampling? So the potential role of an MRI in a clinical practice, it could be potentially avoiding a biopsy, but I just brushed upon that. But more importantly, guiding a biopsy in a previous negative biopsy setting or in patients who are undergoing active surveillance. And even defining the disease risk to maybe see if they have more aggressive pathology than their initial biopsy showed. More research is actually being done also on what we call Artemis image guided and navigation. And this is basically where they try to superimpose or try to computer image tries to correlate the ultrasound images with what we see on MRI. So if we find a suspicious focus on MRI, the computer will tell us where exactly on ultrasound to biopsy. So in conclusion, prostate biopsy is generally good at detection but lacks sufficient accuracy in assessing disease risk, focality, and volume. Strategies for improving the predictive ability of biopsy include increased sampling, computer spatial distribution, and addition of imaging. MRI has a role in selecting patients for repeat biopsy and guiding the biopsy, but is not yet ready to replace the biopsy.